All right, so today we got the legend track coach Dan Pfaff again, and we already done this multiple times, so I'm not gonna ask you to introduce yourself. I'm just gonna start. So, uh, nowadays, like if there's like more and more ACL and Achilles tendon injury, so when it comes to like ACL return to play, a lot of the PT will like start by like using different phases of return to play. So, uh, Coach, can you like walk us through your thought process on like different phases of ACL return to play?
Yeah, I'd probably start out by describing the landscape as I see it. I network with a lot of universities and professional teams here in America, and likewise in Europe and Australia and Asia. And I think in North America, the first problem we got is it's a very siloed process. So the athlete has surgery, and there's some immediate PT done post-surgery, and then it's handed off to a PT clinic, and then additional work is done, primarily exercise. And then when the athlete kind of meets all of their guidelines, then they hand it off to a strength coach, probably. And the strength coach puts the athletes through their grid, whatever they currently think is best practice. And then they hand it off to the sport coach, and the sport coach may understand it takes a little bit of time to come back, maybe not, doesn't really have an assessment ability for whether the athlete is coping. So what I'm seeing is these silos where it's handed off and there's no bridge built between these silos. So the seldom does the strength coach or the sport coach know what went on with the surgery, the details of the surgery, or the various types of surgeries you can have. Like, did you have a patella graft? Did you have a hamstring graft? Did you have an allograft? Is it male versus female? Because, again, the research is biased to males, and the female research is nowhere near as deep. So, surgical techniques like the tunnel angle, how deep the tunnel is, the type of suturing you do you do a backup suture, where the graft was removed from. So, if you do a patella graft, now you're rehabbing two tendons. You're rehabbing the patella tendon and the ACL. It's the same thing in the Achilles world. The surgical technique for how they sewed it was there a longitudinal rupture along with a horizontal rupture. There's a lot of variables that go on there, but back to the point. People are not involved in the process all the way through, and they may not have the skill to be involved in the process. So we got to upskill the weight room coach and the sport coach on what to look for and assessments, and give them guidance on how to transition these people and how to assess mastery of these menu items that they should master before they go to a greater degree of difficulty. So classically, strength coaches and maybe sport coaches, early stage, they do a lot of closed chain activities. So reaction, change in direction, decel and whatnot, but it's very closed chain. And then maybe they figure out, well, now we got to segue into more open chain challenges. And then your final litmus test is, in practice where you got all this randomness, and so you had a higher cognitive load. How do we assess that they're coping with that load? I don't think a lot of people have a real good biomechanical model or a grid for assessment on deceleration or change in direction. So if you don't have a grid to evaluate, then we're not really evaluating. So long story short, I think there's a lot of gaps between these handoffs. I think a lot of people are singing from the same hymn book. And then I think that some of our assessment protocols are really lacking.
Hmm. So, uh, I want to follow by, um, I know, I know you use dribble as like the first thing for return to play, especially in the pole. So, uh, can you kind of walk me through that just for a start for ACO, like your ACO like return to play protocol, like from time like from different phases to phases, and like at what time frame, or like after like what assessment you do, then you feel like you can progress to the next phase.
Yeah. So the first few weeks out of after surgery, I try not to put a lot of load through that area because it's remodeling. And a lot of people are in a brace, they're in crutches. They might, if it's an Achilles, they might be in a boot or what have you. So my primarily input is going to be Plan B training. So I might be doing single leg weightlifting on the good leg. I might be doing upper body lifting. I might be doing single leg bike workouts or battle rope workouts to keep cardiopulmonary and biochemistry and nervous system up to snuff. So the first few weeks is about implementing the Plan B program. Like, what can we do so that this athlete isn't detraining hugely on a lot of fronts during this return to play period? So my first stop is teaching and educating and assessing what they can do in a Plan B workout during these early stages, say first 2 to 4 weeks. Generally, most surgeons at 4 weeks will let people start putting weight, on the affected limb. And they're doing exercises, maybe it's, some kind of knee exercise battery in the PT clinic, trying to get extension back or measuring degrees of flexion and all of that. A sidebar, we're using electrostim complex units the whole time. Like right after surgery, we have that on the affected limb. So we're stimulating the foot, the lower leg, the thigh. We're avoiding the knee capsule area, but the hips, the QL on that side, the erectors. So we're doing a lot of electrical stimulation on the affected side, like right away post-surgery. Once they're weight bearing where they can walk to some degree without super compensation, like lateral listing or really leaning forward or whatever, when they can walk relatively pain-free without a lot of compensation and the wound is healed, we don't want infection, then we would put them in the pool and we'd start out like neck deep because that would unload the athlete quite a bit. I don't have access to alter G's and things like that. So I have to go old school and use water. So we would do the various dribble shapes and ranges of motion and heights and whatnot with the water neck deep. If we're not getting swelling or increase in pain report, then we might lower the water to chest deep. And then we'll go through that same deal. We're also doing some basic sprint drill exercises in the water. So like a walking A march and, a walking B march and things like that. If there's no problem chest deep, then we go waist deep and no problem there. And they master all the exercises without guarding, swelling, or pain. Then we might go knee deep, and if that's okay, then we would segue them to the land. Now, these progressions are seldom linear. Like you may have some days where they're okay, and then you got to go back into more offloading. So you might be going neck deep, chest deep, waist deep, and then you get a little bit of a hiccup. You might have to go back to chest deep for a few sessions until things calm down. So these progressions are seldom linear. It's a little bit of a roller coaster. Once we're on land, then we would experiment with, at walking speed, can they do the various dribble shapes and heights? And then we start introducing changes in speed. So can they do it at walking speed? No problem. Can they do it at jogging speed? No problem. They do it at half speed? So it's kind of you earn the right to go more advanced. So you got to show mastery No increase in pain report, no increase in swelling, no increase in compensation patterns. You've got to be clean before you go to the next level of challenge. And then we probably correspondingly at some stage do our rudiment jump series in the pool with the same idea, starting neck deep, chest deep, waist deep. So we kind of run parallel streams with the dribbling in the rudiment jump series uh, as a cornerstone for assessment. And we're monitoring things like, are the joints amortizing congruently? Are they extending in a synchronized manner? And we're constantly looking for compensation patterns that are red flags. So if a person's listing a lot more to the right than the left, and the injury's on the right, then we know that there may be a hardware problem, or they're still afraid, or there's some restriction in the joint spaces. There's some reason why they're listing to the right. People list in order to increase power output. So the reason a person would lean to that side is because they're not generating enough force in a timely manner.
So does that, can I understand this way, like that you're probably not gonna use a lot of like how much force he can produce on a leg extension or leg curl to dictate like should we progress or not. It's more like, oh, when he do the dribbling on neck deep or chest deep, it looks fine, no pain, then we can progress, or like rudiment jumps.
I think clinical tests are fine, but say you're doing a leg extension, you're really measuring the output of the knee joint, a single joint challenge or assessment without gravity, because you're usually sitting in a chair or something. So to me, that assessment is a little bit biased. There's no gravity going through the structure, and it's a single joint assessment. So early days, I think that has value. There's plenty of research that say you need to be here and this timeline, you need to be able to do that. But I don't put all my eggs in the clinical assessment battery. I want some assessment where I've got gravity on the system and they're using multiple joints simultaneously like they would in the real world.
Hmm. How about like force plate testing? Because force plate testing or ACL return to play are huge right now.
Yeah. Well, I think that's good. I mean, most people are using some form of isometric stimulus to aid the remodeling of the tendon. Most of this is biased to overcoming, meaning they're pulling against a resistance. It's a little bit harder to get isometrics in a yielding format. You'd have to have weight on their back or on their torso. And it's pretty hard to load an athlete at a level you need to load to get a stress shielding response in the tendon in a yielding exercise. So I think force plate data is, valuable. I think our assessment, we need a lot of layers. So we need clinical assessment, we need weight room assessment, maybe force platform assessment, maybe a video assessment, where we're looking at the kinematics of the movement that they're doing. Because I've had a lot of athletes that are really good compensators. The force plate says they're in pretty good place, but then I look at their body shapes and I'm like, man, they're still compensating. They figured out a way to compensate and rig this system, and the force plates are not giving us all the information that we need. So, Matt Jordan, a good friend of mine in Calgary, does a lot of rehab. He kind of has two streams where he's looking at kinetic data, the force plate data, but he's also looking at the visual data overlay. So you could have a person figuring out a way to have pretty good concentric data, fairly good eccentric data, but the body is listing. And to me, they're not out of jail if I'm seeing that.
Nice, nice. So another question is, because you mentioned that you use like a swimming pool, and it's because you don't have access to AutoG. But if you have access to AutoG, would you use that?
Yeah, probably. I don't have as much experience, so um, probably have 30 years of data using swimming pools and maybe 5 people that have used Alter G. So my data set on Alter G use isn't nearly as deep.
Cool. And another question is, um, so typically an ACL injury, like if you want to get an athlete back to like play, return to play, it's probably gonna take like 10 months or like a year or over a year. Like in your experience with your like return play protocol, is that gonna help them come back faster?
Well, there's a lot of variables there. The type of graft, the quality of the surgeon, uh, what substances did they inject pre and post-op? Like some people use stem cells, which changes the equation on timeline and efficacy. Did Usually when an ACL goes, there's cartilage damage, so they usually have to do cartilage repair. So where was the cartilage damaged? What type of damage did it undergo? So a lot of times we're not just rehabbing one variable. So we're rehabbing, say, a patellograft, we're rehabbing the ACL and the patella and probably the medial cartilage. So you're really juggling kind of three balls here, not one ball. So that's going to affect the timeline quite a bit. Um, Hamstring graft versus patella graft, the research shows those are a little bit different timelines. And then we got the problem if we did a hamstring graft, now we've got to rehab the hamstring and we got to rehab the fascia surrounding the hamstring because they just go in there and harvest. They don't really pay attention to the fascia. So we may have inhibition from the hamstring that's affecting the output of the knee. And, we're saying, well, maybe the ACL isn't healing right or on time or whatnot, when really it's a hamstring that's restricting the progress. So I think it's pretty important that you identify all the balls that you're rehabbing, and that's going to affect timeline. Dr. Jordan's work, in his opinion, you're not totally out of jail for about 2 years. It doesn't mean you can't do sport, you can't do it at a high level or whatnot, but kind of like that 2 year window, if an athlete sails through that and they've had pretty good medical support around them, the chance of re-injury or injury in the opposite side is reduced. So we're seeing a lot of ACL goes on the right, and then 18 months later, the ACL goes on the left. You know, Interesting phenomenon. I think a lot of that is these processes that we're talking about were kind of ignored, like everybody was focused on the injured side and they ignored the non-injured side. And then the non-injured side starts overworking, or an athlete develops compensation patterns to protect the surgery side. And now that puts the opposite side at risk. So that's why I think it's so important to develop assessment skills of these athletes in games and in practices when they're doing change in direction activities and rapid decel activities and platform data. A lot of times in the rehab process, we kind of see as what we call a Z pattern. At first, they're leaning on the side that's not injured, and then 4 to 6 months in, they start balancing out. And then there's a few months where they actually overload the injured side, and then it goes back to the uninjured side. So it's kind of a Z pattern through this process. And if we're not monitoring these compensations and these drifts, I think we open ourselves up to a similar injury on the opposite side of the body, in my experience.
Hmm. So, because I think this year in the NBA, they actually have like two or three athletes. They tear his Achilles tendon, and I think both of them actually have an ACL before, like a year before, or a few years before the Achilles tendon. So, is it kind of the same concept you just mentioned?
Yeah, I'd be curious if the Achilles went on the side of the ACL surgery or on the opposite side. That's always interesting to me. Generally, Achilles injuries occur when the shank, the lower leg, has high angular velocity. So the athlete is exhibiting poor eccentric control as that ankle is yielding. And then it kind of blows through that isometric stop point or end point. And so what we see is a rapid collapse of the shin, and then it just keeps going. There's no wall that should stop it. And that's when the Achilles. So if it's on the affected side, I would say generally they were overusing ankle closure to express force. If it was on the unaffected side, then I would say it was a compensation pattern where they were using ankle closure to increase power output because the injured side wasn't producing the right amount of power.
Okay, so talk a lot about ACL. How about Achilles tendon? I know like uh the return to play for Achilles tendon are probably similar, but when it comes to Achilles tendon, I think there's gonna be a little bit of debate about like should we gain like the full range of dorsiflexion on the injured limb for Achilles tendon? Like, what are your thoughts on this?
Well, I think the drivers of Achilles tendon injuries are numerous, and a lot of times it's a hardware problem upstream. So if the athlete has chronic sacral pelvic ilium issues, then eventually that stuff starts tracking down to the knee. If the knee weathers the storm, then it tracks down to the foot ankle complex. So in a lot of cases, it's a hardware issue that's causing the the talus calcaneus tib fib distal to do something it's not really designed to do. They're going through an extreme range of motion at a high velocity and no inability to stop that movement. So it could be a hardware issue. It could be um, intrinsic and extrinsic muscle coordination. So we see a lot of gastric soleus disorder in athletes fighting Achilles tendinopathy. I think my bias is I think people are running scared on Achilles, so they're doing a lot of what I call positive toe riser type stuff, and they're not varying the foot axis position, toes in, toes out, toes straight ahead. It's going to change the dynamics of those intrinsic, extrinsic muscle firing patterns. So I think we're kind of training these guys into the injury currently, sadly. I personally only do negatives. So I start with the foot parallel to the ground and we just work the negative, the drop part of the movement. And we use three axes positions and we kind of cycle eccentric workouts with isometric workouts. So I'm trying to tick a lot of boxes on developing control of this angular velocity of the shank closing and developing an isometric stop point. So if it does fail, the isometric moment will come in and kind of prevent a massive rupture.
So, it's actually really interesting that you brought up a lot of like the Achilles tendon issue is probably some of it is because the lumbopelvic or like sacrum issue. Can you like dive a little bit deeper on that?
Yeah, so in gait, the ilium should go anteversion at toe off and then move back towards a more neutral position during the leg recovery. And then as the leg swings out and sweeps back into the ground, there's actually retroversion. So the ilium moves during gait. It undulates and it oscillates and it undergoes anteversion and retroversion. So It's a gyroscope, if you will. So on the front side of the body, the anterior gyroscope is the pubis symphysis. So is that moving? Is that cartilage, in good shape? Is it alignment? So that's our front side assessment. The back side assessment is sacral movement. Does it nutate and counter nutate? Do the iliums go anti and retro? Do the iliums flare? So the ilium flares out during mid stance. So are those movements existing? Are they proper? Are they within the bandwidth of expectations for a player and at that level or that stage of their career or that stage of the season? If those are restricted, now you've got a kink in the hose, so to speak, power-wise, because power is generated from the center of mass outwardly. So if there's a disconnect or a chink in the hose and the ilium's not moving well, then the more distal structures have to pick up the slack. They have to do more work than they were designed to do because the ilium's not doing its job. And so it's kind of a domino effect. And wherever you got a weak link in the chain, it's going to show up. So if I got tendonitis of the knee or tendonitis of the Achilles or whatever, my first stop is to check the sacral ilium environment and assessment to make sure that's not a driver. And so some athletes, it's top down, it's the pelvic function downward. Some athletes, it's bottom up. So they could have really poor foot structure or foot control, or those joints might not be in the right alignment, and that's causing stuff upstream. So I think that's probably where we've got a gap in our assessment protocol is how do we assess the movement of the foot? The foot has 26 bones. How do we assess those bones are moving, they're gliding, they're rotating? How do we assess the proximal and distal tib fib that it's rotating? It has good ER, IR, that it glides, it spreads when it's supposed to. And then upstream is how's the femur moving in the hip socket? And then more upstream is how the sacrum and ilium are working. So
Hmm.
this is what I mean when I say there's a hardware issue. If any of these joints are not operating the way they should, then soft tissues pay the price for that. So if you've ever fallen and had an upslip of your clavicle or whatnot, it restricts all kinds of motion in your shoulder, until that calms down or you get it adjusted or what have you. And that's what I mean. If you have a real bad hardware problem, things distally from that problem are going to find a way to keep moving, but not in the best way, or in
Hmm.
a more restricted way, perhaps.
Hmm. That led me to the next question. This probably is a stupid question, but I'm gonna ask it anyway. Since like you mentioned, if there's something going on the kinetic chain, maybe on the top or at the bottom, it's gonna affect somewhere else. Do you do like the whole like static movement assessment, like SFMA, those kind of stuff?
I think I'm not a tribalist, so I think any type of assessment has value, but if that's your only layer of assessment, I think you're leaving money on the table. So there's clinical assessments. PTs have all kinds of movements and movement challenges in the clinic. And a lot of these, you're either prone or supine or standing. You're not moving through space. And a lot of these assessments that are marketed in social media, a lot of them are what I call static assessments. The athlete's not moving through space. So that's why, our rudiment jumps and our dribbling and whatnot, the athlete's moving through space. So we're getting feedback and information of how these joints and systems are interacting against gravity while the athlete is translating across the ground. So a static assessment and a translational assessment are night and day. So I've had people, the PT gives them a green light, the weight room guy gives them a green light. They can do all the lifts right at a good load. And I put them on the ground and they're terrible.
Mm, nice, nice, interesting. So I want to go back a little bit. You kind of mentioned this already, but still. So, um, is the Achilles tendon return to play protocol kind of the same with ACL?
For me, it is. For me, it is. And if you send me a text, there's a really good paper by Tom Mislinski on the global overview of return to play. He works with the NFL Player Safety Commission, and I'm happy to share that paper with you. It's a really nice synopsis of, kind of where we at, kind of a meta-analysis, if you will, on return to play designs and programming and assessments.
Cool. So, the next topic I want to ask is about like groin injury or groin pain. I know we kind of talked about this last time, but still, uh, can you kind of like give me your thought process on like why is there a lot of like groin injury like recently?
Well, you're probably not going to like what I have to say. Just like we say, people are biased to positive toe risers for Achilles prevention with the foot axis only in one angle. I think a lot of our groin problems are coming from exercises that are anterior chain biased. We're not putting challenges on these people rotationally. So, like Copenhagen protocols, there's no rotation on those. It's all a test in one plane. And you're not really experiencing axial load gravity. So, testing the adductor in a side posture versus an adductor in a standing posture is night and day. Plus, a lot of these tests are kind of isometrically driven or eccentrically driven. And the injuries usually occur during the interface of these types of muscular contractions. So there was a big concentric moment and then an eccentric moment and probably an isometric millisecond moment interfaced in there. And it was the disharmony that caused the injury, not the absolute value of strength or the capacity of strength. It was a disruption in synchronization or rate coding, if you will, neuromuscularly. So a lot of these injuries occurred in a fatigue state. So what I think is happening in a fatigue state is coordin global coordination is diminishing, and then that means specific coordination is diminishing even exponentially more. And so for me, a lot of these groin injuries, when I see them in ice hockey or NBA or NFL or AFL or rugby or European football, I see people generally in a fatigue state doing a real poor job of motor execution on the task. And we, it would be insane to put people in really bad positions consistently in a workout, trying to build resilience or capacity to prevent those. So the antidote is to make sure these people know the ABCs and change in direction. They know the ABCs of body control, segmental control, joint synchronization, and rapid decel and pivoting moments. So we're always analyzing on these injuries. Did the injury occur during the entry to the pivot, at the apex of the pivot, or on the exit of the pivot? And then did they occur while engaging a person or were they freestanding? There's a lot of variables there. But the consistent trend analysis I see is people doing change in direction or decel really poorly. Like, do they know where to put the pre-penultimate step and the penultimate step and the pivot step and how to change their torso position? Do they know how to lower the center of mass during that process? So a lot of these groin injuries that I see on film, person's in a very upright stance and they step laterally hugely and they're going down as they step laterally. So they've had no pre-penultimate or penultimate. They just do a massive drop all at once with a big lateral step, usually with their torso quite upright. And if you know a little bit about anatomy, that's not a great thing through the inguinal line or the pubis or any of the adductor origin muscles. They're not designed to handle forces or execute forces in those postures. So I think a lot of our problem is, I work with a lot of guys in the off season. No one's ever talked to them about what are the rules for decelerating or what are the rules for change in direction. They don't even, yeah, the great ones will break those rules, but it's kind of that adage, you got to know the rules before you can break them because then you know what risk you can take if you're fundamentally sound. And a lot of these guys and gals are not fundamentally sound.
Hmm. I was gonna ask a question, but you kind of already answered it anyway, because you mentioned that a lot of times these guys injure because they're exposed to like bad position and they don't know how to do penultimate, pre-penultimate, and the body angle. And I was going to ask like, in a sport like football or like basketball, it's a chaotic sport. A lot of times they don't have the luxury to do those stuff in a chaotic situation. But you kind of already answered that. You have to teach the basic first.
Yeah, I mean, does close chain exercises transfer to chaos? No. But close chain can close the gap on tissue tolerance and work capacity, so you're not jumping a big abyss, so to speak. I think also if there's repetition to basics, then that becomes an operating system more so than if you don't have an operating system. So this is where I disagree with a lot of the eco-dynamics folks. So, well, they'll figure it out. Well, no, they won't.
Hmm. All right. So another question is like you mentioned uh on the foot, do they have enough mobility or stability around like the 26 bones? Recently, I think the NBA just published a research that a lot of the basketball player actually have their metatarsal joint and subtalar joint are actually stuck at like the years of 21. So how can we do about that?
Well, your best approach is to have a good manual therapist that can assess these joints and then mobilize these joints, on a regular checkup. Sometimes the shoe wear that they're wearing is promoting these problems. So assessing shoe wear is super important. So those would be my first stops. Like clinically, are these joints, moving the way they should? Do they have range, the way that they should? And then I would, go to a film and I'd film them on various tasks and see how the shoe wear is interacting. So a lot of these guys in these designer shoes have super soft midsoles and, maybe they have a carbon plate in there fighting off an MTP joint or whatnot. The minute you myopically address a foot dysfunction, you've created chaos in that whole foot. So, a lot of guys will default to orthotics or different plates or whatnot. And, in my opinion, there's probably a little bit more money on the table if we really had a good manual therapist.
Hmm. Nice, nice. And That also lead to another question that you also mentioned earlier in our conversation is um, the can the sacrum do nutation? Can a nutation can a nominate move properly when they walk, when they run? But if we talk about like athletes like basketball player or football player, a lot of the time like one side of the sacrum or the SI joint is stuck. And that happens to like probably most of the high level athlete. Does that mean that we are going to, like you mentioned, having a good like manual therapist is going to help that and like just try to like mobilize that?
Well, I mean, when you mobilize, my first question is what is the shelf life of that mobilization? Does it last for the workout? Does it last for a couple days? Or does the first time down the floor they're back to dysfunction? So then you got to peel the onion a bit more. What's driving this dysfunction? What's going on that's creating this desire to return to abnormal movement or abnormal positioning? And, that's kind of the art of really good therapists. They peel the onion and eventually they find some of the drivers that are promoting the pelvis to do what it's doing. So my bias is I want a really good manual therapist, but then I'm on the manual therapist. Okay, like we got the movement and it lasted a day. Why did it only last a day?
Hmm. Great, great. I love this. I love this. All right. So enough for the return to play uh talk. Next thing I want to talk is like a lot of the physical therapists or a lot of strength coaches, they're going to talk about gut movement when it comes like change of direction or like rotational sports or like even sprinting. Do you think that like the whole conversation about like gut movement is really influencing athletic performance a lot?
I'm not familiar with the term.
Like when they do jump, we basically squat down and then the gut follows and then it goes up, if that makes sense.
So organs
Yeah, yeah, yeah. Organs.
above my pay grade. Can't help you there.
Okay. And next thing is what about breathing mechanics? Because like we mentioned earlier, a lot of athletes going to have like SI joint stuck and it's probably gonna also have like scoliosis. Do you teach them like breathing to like correct those stuff?
Well, I don't know that you'll ever correct it, but can you mitigate the negative effect of that? So consistently, we see athletes with bad pelvic control really have bad diaphragm movement. So, there's therapeutic moves to free up the diaphragm and promote better diaphragm movement, which has a knock-on effect for breathing. Um, Breath is a super important variable. I mean, most therapists incorporate some kind of breathing pattern into their therapeutic work. I mean, women give birth, have all kinds of breathing techniques to control pain and the ability to execute the delivery. So we know breath is powerful. Eastern movement arts are deeply tied to breath. Qigong, Tai Chi, any of that. I do Qigong every morning, so I have 8 different breath patterns that I work on that are problematic for me. So, big believer that breath has value. I think the problem we get into is what we talked about earlier, the tribalism, like this technique is going to get me out of jail. If I get an athlete breathing better and the diaphragm's moving better, that doesn't mean that SI joint's going to move well. And give it a chance to move well, but there might be other stuff driving the issue, so to speak.
Nice,
So
nice.
I think the danger, what we're talking about here is in reductionism. We're trying to come up with a tool that will get us out of jail. And maybe I'm not clever enough, but in 52 years, I've never found a Swiss Army knife that gets me out of jail. in the return to play world.
Hmm. Nice. So last question before I let you go. Uh, Nowadays there's like PT or DPT doing like strength coach, DPT doing like athletic trainer. It seems like PT is taking over like everything. So what like are some like recommendation or like advice for you to like give like young strength coaches to be better or like to help them get a like job since PT is taking over everything?
I think it's human nature to put medicine on a pedestal. Whether it's a surgeon or a physical therapist or whatnot, we just feel like those people are more educated, more experienced, better vision of what needs to go on. That's just like there's good surgeons, there's bad surgeons, and there's average surgeons. And I think the same thing exists in PTs or ATCs. So my recommendation to young strength coaches is learn about therapy and sports medicine so that you can have intelligent conversations with these people and network with these people and have them see your value, that you're just not a meathead strength coach, that you understand there's way more to the equation than just lifting weights. So I think we've got to expand our portfolio as S&C coaches where maybe we don't get a PT degree, but we can have intelligent conversations with medical practitioners about what's going on.
Mm,
Because
nice.
the challenges that we can present in the weight room are a lot different than a challenge physical therapists can present in a PT clinic. And a lot of PTs may not understand training theory or mitigation strategies. Like, you're in the NBA, you're playing 4 games a week, you don't have time to do classic PT exercises to remediate an injury. This guy's got to play. So, what's your triage methodology, your contingency methodology to keep this guy on the court while you're trying to put out the fire? They don't teach that in medical school.
Nice, nice. I love it. I love it.
So, I would like to see our PTs and strength coaches become more of an EMS mindset. You pull up to the car wreck. First thing is, this person, can we keep them alive? And then what injuries we got to secure before we put them in the ambulance to send them to the hospital. That's kind of the early stage triage medicine. And I think a lot of times that's what happens in a game. A guy goes down and we got to assess, should we put him back on the court or not? What is our assessment tool? What kind of intervention can we place upon this athlete to see if we can put him back on the court? That's EMS medicine. That's not clinical medicine. There should be clinical background and support for whatever we're doing with the intervention. But at the same time, lost man hours are a key KPI in the NBA. And if this guy's losing a lot of minutes or games, then we're not doing a good job.
Hmm.